Welcome back, RevDivers. We are super excited to talk to someone special today. Before we dive into this, I got to tell you, we recorded this intro a couple of times. We're having serious technological challenges today, and it was an act of sheer perseverance to get to you. I had a whole joke about taking life one bite at a time, and that's why I wore my Pac-Man t-shirt, and it's like it was a jinx or something. So I'm not even going to do that whole spiel again. Instead, I'm going to introduce you to our guest. Today, we are chatting with Dr. Baktari. We are so excited to have you on the show today.
Oh, thanks so much for having me. It's a big honor. I'm very excited.
Yeah, thank you so much for joining us. You know, you have such a varied wealth of experience and background, Dr. Baktari. We'd love to get an opportunity to kind of hear about who you are and what you've been able to accomplish in your career and share that with our audience.
Oh, well, thank you. Well, the cliff version is, I was a pretty straight arrow, went to college, medical school, residency, fellowship, kind of the straight arrow. And then got and started practicing clinical medicine, became a senior partner in my group. I specialize in pulmonary, critical care, internal medicine. And then became a senior partner, and eventually sort of one door opened another, and I started doing administrative medicine as just a little side thing, just to keep the days interesting. And then one door opened to another, and next thing you know, I wound up being dragged into the health insurance world and working for health insurance companies, and being medical director for Anthem Blue Cross Blue Shield and the Culinary Fund. And then simultaneously before that, I was assistant professor in 3 medical schools across, along my career. So I did a lot of teaching. So I got to see the teaching world and then the insurance world. And then I also had an opportunity, which was a lot of fun to, be working for hospitals, being medical directors for hospital chains and what have you. And so, and then last part of what we've been doing is I kind of rolled all that into, and we've eventually opened up, 2 somewhat related healthcare companies. So I've been the CEO of those since 2009 and growing those. So kind of evolved from clinical, professor in clinical medicine to hospital insurance, and then entrepreneurship and startups and stuff like that. So it's been an evolution.
Wow. That is, I love that you said you started off kind of as a straight arrow, and then you went in so many different directions. And I think that's true of a lot of us in healthcare. Like, I don't think any of us started and then stayed specifically in that one area. It's actually one of the things I love about working in healthcare is just the different projects that we get to work on all of the time and keeping it interesting, like you said. And so I guess my first question for you, because you brought that up, right now, today, what is the most interesting thing going on in our industry from your perspective? And I know that's really sort of an off-the-wall question, but there's a lot of intriguing things happening. What is the thing that you're really kind of keyed into right now in the industry?
What I'm seeing broadly, which no one really talks about, is really healthcare consolidation. That's really what's happening. I don't know. People don't want to talk about it, but it's true. 10 years ago, we had 10 cellular phone companies. Now we got 3. 10, 15 years ago, we had 10, 15 airlines. Now we got 3. And that's what's happening. It's the same script for, the cellular phone industry, same script, because it's the same people, by the way, Wall Street and equity money. It's the same people doing the same thing. So we know how this is going to end, because have you tried calling like Verizon recently and seeing how many hours it takes for them to pick up the phone? So we know tried to, 10 years ago, to pay for your bags to get on a plane, like nobody would have even dreamt of it. But but that's what happens when you get consolidation. Quality and other things go by the wayside.
It's interesting. Yeah. Oh, go ahead, Kim.
No, I was thinking about, the the reasons why that consolidation continues to happen in the industry. I mean, there are a lot of reasons. As we were kind of getting to know each other and talking about the revenue cycle model and all of the varying complexities that go into having a successful revenue cycle, there's definitely an opportunity for burnout on that end, but then also on the clinical end, right? I mean, as a physician, I'm sure you've had colleagues who, or even yourself, have kind of expressed, concerns about burnout, and thinking about like what the industry looked like, maybe 40 years ago compared to what it looks like today. What are your thoughts about, that evolution?
Well, I think because you're in the business of, revenue cycle and reimbursement. So let's start with that. I mean, just the big elephant in the room, which is, I think when you go and look at this from a satellite perspective, right? What doctors and hospitals and people were getting reimbursed for services in 1970 versus 1980 versus 1990 versus 2000s and the 2010s. And now, I mean, if you plotted all that, what somebody gets reimbursed for an office visit, for a colonoscopy, for an appendectomy, I mean, that graph is only going in one direction. Okay. It's like, if you plot it over time, it's going down, even when adjusted for inflation. So you're, by definition, going to make less money for that same thing 4 years from now than you were by definition. I mean, could you luck out and maybe that one procedure doesn't get hit yet? But it's just a matter of time. So you're going to make less money, okay? And here's the thing, your costs are going up. So think about this analogy. Let's say in 1970, I tried to sell you a restaurant. And I say, I want to sell you this restaurant, and here's what you can charge for your entrees and blah, blah, blah. But here's the rule. Every year, I'm going to force you to lower your prices, or what you get for, spaghetti and meatball dish. Okay. Every year, I'm going to force you to take less, and your costs are going to go up. Your rent's going to go up. What you pay the staff is going to go up. Your insurance is going to go up. Would you buy that restaurant if that was the deal?
Exactly.
Exactly.
And not only that, but we're going to judge you on the quality of those meatballs,
and make you and just the work we're going to get, extra work we're going to give. I didn't even get there. You beat me to that. So if you really
and
think about
the customer satisfaction,
yes.
Right.
How quickly did you get that meatball out?
We're gonna put all this metrics on you, and by the way, this whole electronic medical records, which is gonna like actually increase your work tenfold. But we're gonna make you do that too. So yes, we get it all. But that's really what you're signing up for. You're signing who gets into a business that by definition their reimbursements for any particular work will go down year over year.
Exactly.
And they're so anyway. So I think looking at it from so people listening to this are like, well, so how did medicine survive this? Well, they survived by doing some shtick. So back in 1980, your typical primary care doctor, I mean, I was obviously in clinical medicine then as a kid, but back in 1980s, I mean, a doctor would, see 15 patients maybe a day. So as the years roll by and his office manager knocks on his door, listen, looks like, our reimbursements are going to go down 10, 20% next year. So he's like, okay, instead of seeing 15, I'll see 17 patients today. I'll stay an extra hour, but however I do it. So we spent the last 20, 30 years, doctors and healthcare just trying to get more volume for the same amount of time. Okay, so now your primary care doctors seeing 30, 40 patients a day, or hospitals seeing 30, 40 patients a day. I mean, that's really, and then so shtick number one, shtick number two, let's start doing ultrasounds in the office. Let's start doing nerve conduction studies in the office. Let's start selling vitamins in the office, and let's start doing Botox in the office. These are all this is all a response to what's going on. So when you come, and then lastly, now okay, so we maximize, look, at a certain point, you can only see so many patients, even if you're crazy. But then you do the shtick where you start doing laboratory testing in your office and, you know, this kind of shtick. But that's just meant to, okay, you're going to cover my reimbursements. Okay, we're going to get a revenue source somewhere else to make up for it. And then last, by the way, I'm not agreeing with that or condoning. I'm just saying what the evolution of, and then the last thing has been basically saying, okay, I'm not actually going to see you. I'm going to hire a PA, a nurse practitioner, to see you. So there you go. So, I mean, if you plotted the percent of people who went to see their primary care doctor and actually got to see them in the 80s, 90s, and now in the last 5 years, the likelihood that you're going to get to see your primary care doctor is dropping. I mean, nobody can deny that. You know, they can say, well, not my doctor or not that doctor, but globally it's dropping. You go to an urgent care 5 years ago, you go into an urgent care now, it's a different landscape. So these are all strategies where, in response to this, and I'm not saying who's right or wrong, I'm just saying when you cut somebody's reimbursements and their costs are going up, they have to respond somehow. It's probably more than you wanted to know. I
agree with you. And, you know, you talked about kind of this cycle of behavior, right? And we're seeing like a lot of consolidation of things. And we were talking about this, it was maybe just a couple of weeks ago, Kim and I, we were talking about this, that, you know, if you looked back to the 50s, the 60s, you know, or even further, people were getting their milk delivered to their front door, and we're doing that now, shipped in Instacart and any grocery delivery service. And people were having their physician come to their home to see them. And we're doing that now in person and via telehealth. And it's like, at some point across all of these different things, we immediately like walked away from one method and went to a completely different other method, like a pendulum swing, when the genuine balance was kind of somewhere in the middle. And I think that's what we're lacking right now in healthcare, is that balance, you know, that balance is so sorely needed. And when you see these, you know, declining, to your point, declining revenue, right? And declining time with the patient and declining outcomes. And so there's all of these things being put into place, and this huge shift away from fee-for-service to get back to saying like, hey, no, we should value quality over quantity. And I think we're all agreed we should be valuing quality over quantity. But how do we get back to a point where we're being incentivized to do that? So there's all these really complicated methods and value-based arrangements. And we had a working situation actually previously, that if we just kind of like went back a little, we don't have to pendulum swing all the way back, but like, let's come a little bit back toward where we weren't being so heavily managed.
Yeah.
That it
well,
was,
you know,
yeah,
if I can interject, I think what you're saying is we should have tweaked the system. And I agree with you, because look, again, this is all candid stuff, so I'm not going to sugarcoat any of this. So that old system, while it sounds so nice, had abuses too.
Oh, for sure.
Right. So there were doctors and healthcare professionals maybe doing, you know, when you're getting paid for everything you do, no questions asked, you know,
exactly.
which was back in, you know, 80s and whatever. You know, you could see how human nature being what it is, that might potentially lead to, in certain cases, I'm using all the qualifiers, you know, extra stuff being done that potentially could have been avoided. And so this whole idea of why managed care came into play is to address that, to address the excesses of having just like, okay, you do something, you get paid. And that's a good thing, because obviously at the end of the day, we want quality. We want the patients to get the right thing. You know, we need to be looking out for the patient. So I think the excesses were not good, and I'm not proud of it. And I'm glad it was addressed. But you know,
we definitely need oversight, right? We need some
Right.
elements of oversight, but
Right.
there's got to be balance. You know, Kim, what are your thoughts?
Yeah, when we think about the shifting environments and the landscape of medicine and reimbursement, We also think about the workforce who is kind of shouldering all of this on their backs, right? And they have been involved in the 50s and the 60s and the 70s and 80s, 90s and the 2000s. And they have had to really kind of adjust their abilities and their skills to every time these changes happened in the healthcare system, right? And the public health emergency absolutely strained all of that, right? It just really it strained it all. And now I think where we are is we have a workforce who not only are they exhausted, some of them feel underappreciated, maybe even underpaid because reimbursements are where they are. So it's also, I think, a great opportunity for healthcare leaders and physicians alike to really think about how we shift the culture, whether it's the culture of our individual organizations, whether it's advocacy to advocate towards changing regulations, maybe on the state level and the national level, because I do think that as healthcare leaders and as physicians, we have a lot of power, right? We understand the needs of a community that maybe policymakers don't quite get. So we can advocate on their behalf. We can advocate on the behalf of our individual businesses, because technically, medical facilities are businesses. And we can also advocate on behalf of our workforce, not only, from a legislative perspective, but then also making sure that we're bringing in the resources that our teams need, right? So bringing in technology, bringing in service enhancers when they're medically appropriate, bringing in training and education. Serotonin. Yeah.
Yeah, it's a challenging place that we're at in the industry right now. And I think to your point, Kim, we have to remain positive, right? We have to find what are those things that we can do to affect positive change. So Dr. Baktari, what are, in terms of like the things we can do to impact and affect positive change in the industry overall? Because I do genuinely think that for those of us in the industry, we're all kind of, linked arm in arm. We want to see the industry continue to improve and improve and improve. What do you think are some things we can do to achieve that?
I've come full circle on that. I mean, my position has evolved on that. I just think at the end of the day, what I have seen now in the private sector, starting a company, you just have to have people have skin in the game. And I think, if there was a model where the patients would potentially feel the consequences of, for example, just being aware of their own healthcare, making sure, they're not being prescribed too many procedures they don't need, medications. And then the flip side is to monitor the doctors and to make sure, from a managed care perspective, that they're not doing it to just rein in costs. But I think the patients also, if there was a way to get them dialed in to understand that, if you went to see one doctor and had a blood test, and then a week later you went to see another and he ordered blood tests, I mean, could it be possible that it's the same blood test? I mean, or you had a MRI somewhere else, and now it's a year later. The whole idea to get involved in your healthcare, not only just for financial, but from quality. I always tell people, if you bring the old MRI to your new doctor, and that comparison actually adds information. So I think, how do we get patients more engaged and involved? And also, continue to oversight doctors to make sure that, not that we're getting the quality the patients deserve, and we're getting the appropriate utilization.
Wow. I have to tell you, that is a wonderful place to put a bow on this great conversation. putting the power back in the patient's hands, making sure that we are engaging with them, we're educating our patients. And guess what? Our patients could also be our workforce, right? So we're, as we continue to educate our workforce, they become more informed patients, right?
Mm-hmm.
So it's really a cyclical effect, making sure that we're empowering our patients, educating them, making sure that they're aware of their treatment plans, their financial responsibilities, their options, avoiding white coat syndrome by making sure that our patients feel comfortable in the environments that we're in. Wow, that is wonderful advice, Dr. Baktari. Thank you so much for being with us today. This has been an absolute pleasure spending some time with you. Before we let you go, we would love to maybe impart some of your wisdom in your career, something that you've been really successful at in your journey in healthcare that you might want to share with our audience to inspire them to be their best selves.
Yeah, I think, I think when people interact with the healthcare system, like choosing a doctor, having an interaction with the doctor, I think it's really important to seek out people who really look at you as an individual, understand you. I know we talked about, like, back in the 70s, doctors used to make house calls and they knew your family and they knew everything about you. And I know that it can't exist anymore, but still to develop a relationship with a healthcare provider, whether it's a doctor, nurse practitioner, or PA, and really evolve that relationship and seek out those opportunities, because one of the pitfalls of just going to urgent care every time and randomly seeing a doctor or a PA here and there, I think you lose some of the magic that came with a healthcare provider understanding what makes you nervous, what stresses you out, and what keeps you up at night. Those are not the conversations you're going to have if you're just seeing a new provider every week. And I think I'll give you one stat that I used to tell my residents and interns, when I was teaching. There's a statistic that almost 1/3 of all primary care visits are about reassurance. 1/3. That means 1 out of 3 people are just coming to see you so you can say, nah, that's nothing. Get out of here. Don't worry about that. That's nothing. The gist of it. Actually, I think there was a Seinfeld episode where, George goes to see a dermatologist and the guy, doesn't say that and says, well, let's do it. But, and he's like, well, you should, I think there's this feeling that when 1/3 of the time you go see a doctor, I don't know, maybe something's stressing you out. Maybe, something at home is not right. So you have her wind up in a doctor's office, and the doctor needs to acknowledge that and say, oh, really, I mean, Susie's or Bill's complaints all over the place, doesn't fit any particular, diagnosis. I wonder what else is going on. And, should we ask, should we open up that can of worm, or should I just move on to my next patient? So I think physicians need to understand literally 1/3 of all primary care visits, they just want reassurance that they're not dying of cancer, that, they're not having a heart attack and whatever. And of course, sometimes we need to investigate it, but they're there because some other reason brought them into that office. And they think it's a healthcare reason, but sometimes it's not. And so we need, yeah.
Oh, I was going to say, to your point, I think that circles right back around to giving physicians more time. The greater reimbursement, the more time that they have in the room to recognize that, right? Because you're going to see that in body language and what the patient is saying. If you have the time to ascertain, okay, they just need to be reassured. They just need to feel heard. They just need me to sit and look them in the eyes and tell them that they're okay for a second. That's hard to assess when you're, seeing 30, 40 patients a day running around like, crazy, trying to meet all the metrics.
And to add to what you just said, I on my podcast last year, I reviewed a study about what percent of the time, even when the doctor or healthcare provider is in the room, are they talking to the patient or staring at their EMR? So it was like 70-80% of the time, they're actually staring at the computer. So even with the allotted time that we think should be more, such a high percentage of that visit is, you know, because of some of the things they have to do, whatever. But so it's even doubly challenging.
Yeah.
Yeah.
This has been a great conversation, Dr. Baktari. Again, thank you so much for being with us today. This has been a great insight into ways that we can improve our patients' experience in the healthcare continuum. So, Rev Divers, until we meet again next time, keep diving into those Rev cycles.